Here's a question worth sitting with for a moment. If you have been taking a blood pressure pill every single morning, Amlodipine, Losartan, or Lisinopril, how confident are you that you truly understand what that pill is doing inside your body right now? Not what the label says, not the single sentence your pharmacist printed on the bag, not the 30 seconds your doctor spent explaining it during a busy appointment. Actually understand it, the way it works at a physiological level, the way it can quietly turn against you under certain conditions you encounter every day, and the warning signs that separate a minor inconvenience from a situation requiring urgent medical attention before things go seriously wrong. Most people pause when asked that question. Educated people, careful people, people who manage their own finances, read the news, track their health numbers, and consider themselves informed participants in their own medical care. They pause, and that pause reveals something important, because these are not mild medications. These are not supplements. Amlodipine, Losartan, and Lisinopril are powerful pharmaceutical agents that alter how your heart, your blood vessels, and your kidneys function every single day around the clock for as long as you take them. And yet, millions of people, particularly seniors who may be taking multiple medications simultaneously, swallow them on autopilot each morning with very little genuine understanding of what to watch for, what to avoid, or when something that feels ordinary is actually a signal their body is urgently trying to send. That ends today. By the time you finish reading or listening to this, you're going to understand these 3 medications in a way that makes you meaningfully safer, considerably more confident in recognizing warning signs, and far less likely to be caught off guard by something that was entirely predictable once you had the right information. Let us start with a story, because the story sets up everything else in a way that no abstract explanation can. Walter was 74 years old, a sharp, methodical former engineer who approached everything in his life with the same systematic precision he had applied to his career. He took his medications exactly as prescribed, without exception. His daughter had set up a pill organizer labeled Monday through Sunday, and Walter treated it the way he had once treated project schedules: non-negotiable, documented, consistent. When his doctor added amlodipine to his existing regimen, Walter processed it the way a logical person processes new information. One more blood pressure pill, different name, same general category, no big deal. He would take it as directed, monitor his pressure, and report back at his next appointment. That assumption almost cost him a productive year of his life. 3 months after starting amlodipine, Walter's feet had changed so dramatically that he could no longer fit into any of his regular shoes. His legs felt heavy and full by 4 in the afternoon. He began limiting how much he walked because movement seemed to make the swelling worse. He told his son he believed his circulation was failing. He was genuinely frightened. He was spending time on medical websites reading about heart failure and trying to understand which symptom applied to which serious condition. The actual answer was something far simpler and far more manageable than any of those frightening possibilities. But Walter did not know it, because nobody had ever clearly explained to him that amlodipine, Losartan, and Lisinopril are not the same kind of drug. They all lower blood pressure. That is where the similarity ends. Understanding this distinction, really understanding it, not just nodding along, is the foundation of everything that matters in this conversation. Amlodipine is a calcium channel blocker. It works by relaxing the smooth muscle inside the walls of your arteries, reducing the resistance that blood encounters as it moves through your circulatory system. Less resistance means lower pressure. That is the mechanism, and it is effective, but it is also specific. It acts primarily on arteries, not on the veins responsible for returning blood back toward the heart. That asymmetry is exactly what caused Walter's problem, and we will return to it in detail. Lisinopril is an ACE inhibitor, short for angiotensin-converting enzyme inhibitor. Your body produces an enzyme that plays a key role in tightening blood vessels. By blocking that specific enzyme, lisinopril prevents the tightening from occurring and blood pressure falls. It is a targeted intervention in a specific biological pathway. Losartan is an ARB, an angiotensin receptor blocker. It works within that same biological pressure regulation pathway as lisinopril, but through a distinctly different mechanism. Rather than blocking the enzyme that produces the tightening signal, losartan blocks the receptor that receives that signal. The result is similar: blood pressure reduction, but the route is different. And that difference matters practically for side effects, drug interactions, and how individual patients respond. Three genuinely different mechanisms, three different side effect profiles, three different warning signs to monitor, three different situations where the medication behaves unexpectedly under conditions you might not think to connect to the drug. When you understand these distinctions at this level, you stop interpreting your body's signals with a one-size-fits-all lens and start recognizing the specific pattern that belongs to the specific medication you are actually taking. Walter's swelling was not heart failure. It was amlodipine doing precisely what amlodipine does in a significant percentage of people who take it, a predictable physiological response once you understand the mechanism. Once that connection was identified and properly addressed, Walter was back in his walking shoes within weeks. The medication was not wrong. The understanding was missing. Let us go deeper into that swelling because it is one of the most widely misunderstood side effects in all of blood pressure medicine, and it affects far more people taking amlodipine than most physicians take time to explain during a prescription appointment. Here is what actually happens, explained as clearly as possible. When amlodipine relaxes the small arteries in your legs, blood flows into those lower extremities more freely than before. However, the veins, which carry blood back upward toward the heart, do not relax in the same way the arteries do. Amlodipine's action is preferential toward arterial smooth muscle, so you end up with a physiological imbalance, more blood flowing into the lower legs and feet than the venous system is efficiently returning upward. Pressure builds in the small capillary vessels near your ankles and feet, and that elevated pressure eventually pushes fluid out of the vessels and into the surrounding tissue. The result is the collection of symptoms Walter experienced: puffy ankles, socks that leave deep, slow-fading impressions, shoes that stopped fitting comfortably, legs that feel increasingly heavy and full as the day progresses and gravity continues working in the wrong direction, discomfort and reduced mobility that genuinely affects quality of life. This is not fluid retention from dietary sodium excess. This is not kidney dysfunction. This is not the early presentation of heart failure. In the large majority of cases, it is a predictable and well-documented physiological consequence of exactly how amlodipine works. Understanding that distinction is important not only for accurate self-assessment, but for the decision about what to do next. Because here is where the situation can become genuinely dangerous, not through the swelling itself, but through the way people typically respond to it without proper guidance. Some people see the swelling, become concerned, and decide independently to stop the medication without informing anyone. Their blood pressure then climbs back toward its previous elevated level quietly and gradually, while they feel as though they made a sensible, health-protective decision. Others keep taking the medication, but begin restricting their fluid intake because they assume they are retaining water and that drinking less will reverse the accumulation. This is the wrong direction entirely. Dehydration while taking a calcium channel blocker carries its own set of risks. Some people, like Walter, simply endure the discomfort in silence for months, progressively reducing their physical activity, assuming something serious is developing, and losing months of quality and function they did not need to sacrifice. The correct response is straightforward, but requires knowing it is available. Leg swelling on amlodipine is a conversation your prescribing physician needs to have, not because the medication is necessarily wrong for your situation, but because multiple evidence-based strategies can meaningfully reduce or resolve the problem. Elevating the legs periodically throughout the day, adjusting the timing of the dose, reconsidering whether this specific medication is the optimal choice for your particular physiology and clinical picture. None of these options happen if you suffer silently or make unilateral medication decisions without medical guidance. Now let us discuss lisinopril and what is arguably the most recognizable and consistently misdiagnosed side effect in the entire ACE inhibitor category: The cough, not a wet cough with productive mucus, not the cough that accompanies a respiratory infection with other accompanying symptoms. A dry, persistent, scratchy tickle located in the back of the throat that tends to be noticeably worse at night is essentially unresponsive to the usual remedies: cough drops, antihistamines, throat lozenges, increased fluids, and simply does not resolve the way an ordinary cough eventually does. What makes this side effect particularly problematic from a diagnostic standpoint is its timing. It frequently does not appear immediately after starting the medication. Some people develop it within the first week. Others take 3, 4, or 5 months before the cough appears, and by that point, the connection to lisinopril may never spontaneously occur to them. They have been tolerating the medication without apparent difficulty for months. They naturally attribute the new symptom to seasonal allergies, dust exposure, a respiratory irritation that has persisted after an illness, or acid reflux causing throat irritation. All of these alternative explanations can seem perfectly plausible in context. Consider the experience of a 71-year-old woman named Evelyn, an enthusiastic gardener who assumed her emerging cough was the result of extended time outdoors during pollen season. The timing aligned perfectly with late spring. She purchased antihistamines and used them consistently. She bought an air purifier for her bedroom. She mentioned the cough to her primary physician, who appropriately ordered a chest X-ray that returned completely normal results. 6 months after the cough began, she was still experiencing it. Her sleep was being disrupted nearly every night. She was fatigued, increasingly frustrated, and beginning to worry that something significant was being missed in her evaluation. During her visit, one of the first questions asked was when she had started lisinopril relative to when the cough had first appeared. She went quiet, retrieved her phone, and started calculating. She had started lisinopril 11 months prior to that conversation. The cough had begun approximately 4 months into treatment. She had never made the connection because the gap in time between starting the medication and developing the symptom had made the causal relationship invisible to her. Once the likely cause was identified, and she worked with her primary physician to transition to Losartan, which acts on the same biological pathway, but through the receptor-blocking mechanism that does not produce this type of cough, the persistent tickle in her throat disappeared within 2 weeks. 11 months of disrupted sleep and daily discomfort resolved within 2 weeks, once the right connection was made. Now, and this point is genuinely critical and must be stated clearly, there is a symptom within the ACE inhibitor category that is not a manageable nuisance. It is a medical emergency. If you are taking lisinopril and you develop swelling of your lips, tongue, face, or throat, particularly if you notice any difficulty swallowing or breathing, you do not wait to see if it resolves. You do not call the physician's office and schedule a next-day appointment. You do not take an antihistamine and monitor the situation. You contact emergency services immediately. This condition is called angioedema. It occurs in a small percentage of people taking ACE inhibitors, and while relatively rare, it can progress with alarming speed. The airway can narrow faster than most people expect. This is not a situation where waiting to see if things improve is an acceptable strategy. A dry, persistent cough is a manageable inconvenience worth discussing at your next appointment. Throat or facial swelling that develops while taking lisinopril is an emergency that requires immediate response. The gap between those two situations is significant, and knowing which is which could determine a very different outcome. Now let us turn to Losartan and a risk that is particularly striking because it does not arise from doing something careless or negligent. It arises from people doing what they genuinely believe is the healthiest possible thing. Losartan, like lisinopril, works within the renin-angiotensin system, the body's primary blood pressure regulation pathway. One of the consistent pharmacological effects of drugs in this class is a tendency to elevate potassium levels in the bloodstream. For the majority of people taking these medications with appropriate medical monitoring, potassium remains within acceptable ranges, and this effect is clinically manageable. But layer certain common lifestyle decisions on top of this baseline effect, and the picture can change in ways that neither the patient nor occasionally the physician anticipates. Here is where the situation becomes genuinely counterintuitive. Potassium does not arrive in your system only through bananas or potassium supplements from the pharmacy. It is present in significant quantities in products that are actively marketed, prominently displayed, and widely recommended as the healthier, more heart-conscious alternative to ordinary table salt. Salt substitutes, the products sold in most grocery stores right beside the regular salt shaker, often bearing labeling explicitly describing them as appropriate for people managing blood pressure or cardiovascular health, typically replace sodium with potassium chloride. The practical result of this combination deserves careful consideration. A senior who has been appropriately counseled to reduce dietary sodium purchases a potassium-based salt substitute and uses it generously across multiple meals each day as they would have used ordinary salt because they believe they are making the specifically recommended healthy choice. Simultaneously, they are taking Losartan, a medication that already trends potassium levels upward. The combined effect can push potassium to concentrations that begin affecting the electrical conduction system of the heart. What makes this particularly dangerous is that elevated potassium does not announce itself through obvious, unmistakable symptoms in many cases. It can present quietly as unusual muscle weakness, persistent fatigue that seems disproportionate to activity level, cramping sensations in the legs, tingling in the hands, or a fluttering, irregular heartbeat. In some cases, symptoms are minimal or nearly absent until potassium reaches concentrations where serious cardiac effects become possible. Electrolyte powders, certain meal replacement products, and over-the-counter sports recovery drinks marketed for hydration and recovery also frequently contain meaningful potassium quantities. These are not prescription products. No one thinks to disclose them during a medication review. No one considers them relevant to report alongside prescription medications because they are purchased from a pharmacy shelf or a grocery store. But your body's chemistry does not categorize substances by whether they required a prescription. It responds to the actual concentrations of compounds present in your bloodstream, regardless of how they arrived there. If you take Losartan or Lisinopril and have switched to a salt substitute in the past year or two, or regularly use electrolyte products or potassium-containing supplements, this specific combination is a conversation worth having with your physician at your earliest opportunity. Not because any individual element is necessarily dangerous in isolation, but because the specific combination without appropriate awareness and monitoring can create a problem that never needed to exist. There is a scenario that receives significantly less attention in discussions about blood pressure medications than its clinical importance justifies. What happens to these medications when you become ill? Not seriously ill, not hospitalized with a major acute condition, just experiencing what most people would describe as an ordinary bad few days, a stomach virus with nausea and vomiting, gastrointestinal upset that prevents normal fluid intake, persistent diarrhea over several days, significant loss of appetite, or simply a hot stretch of summer weather during which you are sweating heavily and not replacing fluids adequately. When your body becomes even moderately dehydrated for any of these reasons, the same dose of Losartan or Lisinopril that was carefully calibrated for your normal, well-hydrated physiological state can behave dramatically differently than intended. Blood pressure can fall below appropriate levels. Your kidneys, which are already managing additional stress as a consequence of the reduced fluid volume, become substantially more vulnerable to medication effects that would otherwise be inconsequential. Dizziness, pronounced weakness, lightheadedness, or signs of acute kidney strain can develop more rapidly than most people anticipate based on how the medication has behaved during normal conditions. The medication itself has not changed. What has changed is the internal physiological environment in which it is now operating. The dose that was appropriate and well tolerated under normal circumstances is now operating in conditions it was not calibrated for, and the effects can reflect that mismatch. This represents one of the most practically important pieces of information available for anyone taking these medications. Illness changes the pharmacological rules for these drugs, and if you do not have a clear plan established in advance for what to do when illness disrupts your normal routine, whether to temporarily withhold a dose, what symptoms should prompt you to contact your physician, what specific warning signs indicate a need for urgent evaluation, you have a meaningful gap in your personal medication safety. That plan should come from your prescribing physician before you ever actually need it. If you have never been given that guidance explicitly, the question to ask at your next appointment is straightforward. What should I do with my blood pressure medication if I develop a stomach virus or cannot maintain normal fluid intake for a day or two? This is among the most clinically important questions you can bring to a medical appointment, and it is simultaneously one of the least commonly asked. The gap between those two facts is where preventable problems happen. Consider another scenario that is common, entirely understandable, and carries kidney risks that are rarely explained clearly to patients managing chronic conditions alongside blood pressure. Your arthritis flares, your knees ache, your back is stiff and limiting your movement. You visit the pharmacy or reach into your medicine cabinet for ibuprofen, something you have used for years, something sold freely over the counter, something so familiar and accessible that it barely registers as a medication in the meaningful sense. If you are taking Lisinopril or Losartan, and particularly if you are also taking a diuretic, a water pill for additional fluid management, regular use of ibuprofen, naproxen, or similar non-steroidal anti-inflammatory medications can meaningfully reduce blood flow to the kidneys. In the context of even mild dehydration, the cumulative risk to kidney function rises substantially beyond what any single element of this combination would produce in isolation. The reason this particular combination causes so many preventable problems is a simple and persistent misconception about over-the-counter medications. Patients do not think of ibuprofen or naproxen as real medications in the same sense that prescription drugs are real medications. They are products from a drugstore shelf, available without a prescription, used by millions of people every day without consequence. The psychological category is fundamentally different from prescription pharmaceuticals, which feel more serious, more powerful, more in need of caution. Your kidneys do not share this psychological distinction. They respond to the chemistry of whatever compounds are present in your bloodstream without regard for whether those compounds required a prescription. The interaction between ACE inhibitors or ARBs, diuretics, and anti-inflammatory medications is real and documented regardless of how any of those individual substances were obtained. If you regularly use anti-inflammatory pain medications for arthritis, joint pain, or back pain, and you are taking any of the three medications we have been discussing, this specific combination deserves explicit conversation with your physician. Safer alternatives for pain management almost always exist: acetaminophen, topical anti-inflammatory preparations, physical therapy approaches, or other strategies that address the underlying pain without the same kidney risk profile. You do not need to simply accept the pain, and you do not need to silently accept the risk. There is almost always a better path available, but finding it requires the conversation happening rather than being avoided. Let us spend a moment on something that sounds minor in description, but carries consequences that are anything but minor for older adults. The brief dizziness that occurs when you stand up from a seated position or rise from bed in the morning. The momentary sensation of the world tilting slightly, the instinctive reach for the doorframe or bedpost for stability before the sensation passes. Then you continue with your morning and think very little of it because it was so brief. For many seniors on blood pressure medications, this experience is essentially routine, and it is almost universally underreported to physicians because it seems too small, too fleeting, too ordinary to be worth mentioning during an appointment that covers more obviously important medical topics. Here is what needs to be understood clearly. In older adults, a few seconds of dizziness is sufficient to cause a fall. A fall is sufficient to cause a fracture, and a hip fracture specifically can alter an older adult's health trajectory in ways that persist for years, affecting mobility, independence, cognitive function, and overall well-being in cascading patterns that can be extremely difficult to reverse. This is not overstated concern. This is a well-documented clinical sequence that occurs frequently enough to be one of the primary safety considerations in prescribing blood pressure medications to older patients. The physiological mechanism is straightforward. Blood pressure medications are working as intended, maintaining lower pressure consistently throughout the day. When you rise from a horizontal or seated position, the cardiovascular system needs a brief moment to compensate for the change in gravitational demands. If that compensation is even slightly delayed, blood pressure momentarily drops, and blood flow to the brain transiently decreases. You experience this decrease as the brief lightheaded or tilting sensation you may recognize. Practical strategies address this directly. Rise slowly rather than standing abruptly. Sit on the edge of the bed for 30 to 60 seconds before standing fully. Keep a stable surface within reach for the first few steps after rising. Allow your body the brief additional time it needs to complete the cardiovascular adjustment before committing to full upright movement. But beyond these practical adaptations, dizziness that occurs consistently, dizziness that does not diminish as your body adjusts during the first weeks on a medication, or any episode of near fainting, are signals that warrant a genuine clinical conversation. The medication dose may need adjustment. The combination of multiple blood pressure agents may need review. Hydration patterns may need modification. Silence about regular dizziness when taking blood pressure medications is not a small risk for an older adult. It is a meaningful safety gap. One more area deserves attention because it generates considerable unnecessary anxiety and, perhaps more concerning, encourages impulsive medication decisions that can cause real harm. Home blood pressure monitoring is valuable and should be encouraged, but the way many people interpret their home readings creates problems that regular clinical guidance could entirely prevent. Blood pressure is not a static number. It fluctuates constantly in response to dozens of variables that are entirely normal parts of daily life: sleep quality the previous night, caffeine consumption and timing, current pain level, emotional state, including anxiety about the reading itself, recent physical activity, ambient temperature, whether you spoke or moved in the minutes before sitting down to take the measurement. All of these factors and more influence what your cuff reads at any given moment. A single elevated reading on a Tuesday morning after poor sleep does not mean your medication is failing. A single low reading on a hot afternoon when you have not been drinking adequate fluids does not mean your medication dose is too high. Neither of these individual readings warrants adding an extra dose, skipping your next scheduled dose, or making any unilateral change to how you are taking your medication. What matters clinically is the pattern that emerges when measurements are taken consistently. The same arm, the same general time of day, after 5 full minutes of seated quiet rest without recent movement or conversation, and tracked over days and weeks rather than interpreted moment by moment. A log of consistent readings taken under consistent conditions gives your physician genuinely useful information about how your medication is performing. A collection of anxiety-driven readings taken at varying times under varying conditions, interpreted emotionally rather than analytically, produces confusion rather than insight. The practical consequence of this distinction is significant. When people monitor inconsistently and react to individual alarming readings, they take extra doses out of fear when they were not needed, skip doses because a single reading looked acceptable, call their physician in distress about numbers that in full context were entirely unremarkable, or stop their medication entirely after a reading that frightened them, with blood pressure then rising silently while they feel they made a responsible decision. Monitor with a consistent method. Track readings over time rather than reacting to individual moments. Bring your log to appointments rather than relying on memory or isolated screenshots. Let the pattern, rather than any single data point, inform the conversation with your physician. This approach reduces anxiety, produces better clinical decisions, and gives your healthcare provider the information they actually need to manage your treatment effectively. The fundamental pharmacological reality underlying all of this is important to carry forward. Amlodipine, Losartan, and Lisinopril work through steady, consistent presence in your system. They are not rescue medications designed to be taken reactively when a reading concerns you. They are not treatments that produce benefits proportional to how many pills you take. They require consistency. The same dose at the same general time every day to maintain the stable blood levels that produce the clinical benefit of sustained blood pressure control. Gaps in that consistency allow pressure to fluctuate in ways that carry risk. Extra doses taken reactively can push pressure too low in ways that create the dizziness and fall risk already discussed. Neither the gap nor the extra dose is a safe adaptation to an alarming reading. The safe adaptation is the consistent approach, guided by clinical monitoring and open communication with your physician. Understanding what your blood pressure medication is actually doing, the mechanism, the specific side effects, most likely for the specific drug you are taking, the warning signs that are manageable versus the warning signs that require immediate response, the everyday situations that change how your medication behaves, and the common pitfalls that affect millions of people taking these same drugs is not supplementary health information. It is foundational safety knowledge. Walter's swollen feet resolved when someone explained why amlodipine causes that specific symptom and what could be done about it. Evelyn's 11 months of disrupted sleep ended within 2 weeks of identifying that lisinopril was the cause of her persistent cough. The risks from salt substitutes, from illness-driven dehydration, from over-the-counter pain medications, from rising too quickly, from reactive monitoring, all of them become manageable the moment you understand them clearly. The information your physician covers in a 10-minute appointment is genuinely insufficient to give you what you need to take these medications safely over years. That is not a criticism of physicians who are managing significant time constraints and enormous clinical complexity. It is simply a reality that creates a gap, and that gap is where the preventable problems happen. The goal is to make that gap smaller, to give you the information that allows you to recognize warning signs that belong to your specific medication, to ask the right questions before a problem develops rather than after, and to bring informed, specific observations to your medical appointments rather than vague concern or silent uncertainty. You are taking a powerful medication that changes how your heart, blood vessels, and kidneys function every single day. You deserve to understand it fully. Now you do.